Right, so we'll welcome everybody to this meeting of the Integrated Care Partnership here at Derby City Council. I can't believe it's 17th of April already, it's flying by. So welcome everybody. Unfortunately, I think we've got quite a few apologies today, so if we could do the apologies, thank you.
Okay, we have apologies from Tracy Allen, Stephen Bateman, Avia Bhatia, Carol Camus, Mary Dooley, Duncan Gooch, Kim Harper, Karen Hansen, Natalie Hoy, William Legg, Stephen Posey, Gino Di Stefano is representing him, Mark Powell, Lee Doyle is representing him, Drew Smith, Andy Appleyard is representing Andy Smith, Simon Stevens, Sean Thornton, Councillor Whitby and Julie Patton.
Well, I can say it's a good job we've got a lot of people on the board. Else we'd be in trouble. I'm sorry that some come up. I know for my two councillors at Derbyshire County Council, unfortunately, one has got a childcare problem and one has got a hospital appointment. So, yeah, so it's a shame they can't come. But can we do a welcome to Cathy, new chair of the ICB. Rather than go round and sort of do all the introductions, can I suggest that when you speak, if you just first introduce yourself so that, I think Cathy, to be fair, I think you know most people anyway, don't you? So, yeah. Thank you. Right, so I've got no late items. I'm the chair. Any declarations of interest? None, thank you. The minutes of the last meeting, as far as I can see, there are no actions. Most of it was all for noting. So rather than go page to page, is everybody happy to accept those minutes? Can't see any objections, so thank you. We'll accept those. Thank you. So we get on to the first substantial item in the agenda, and it's the update from the Integrated Care Board. And that's over to you then, Chris. Thank you.
Thank you, Chair, and for colleagues who don't know me, Chris Clayton, Chief Exec of NHS Derby in Derbyshire. So thank you. In terms of our standard process, here's a report from the ICB. I'll take it as read, but just pull out a few salient points. I think the flavour of the report does show the importance of partnerships. So although it's a report for the ICB, the NHS here in Derby and Derbyshire, in many, many areas, it talks about the integrated care strategy, it talks about devolution, and so I think it's a sense of the NHS being integrated with our partners. But the key thing I would pull out, if I can, would be where we are in the planning position. So for colleagues not as used to the NHS planning process as we are now actively in setting the year ahead's plan. It is normal this time of year where we finalise the plan position, and we're working through that now. Clearly, like our local authorities, we've all got challenges in terms of the resources available and the expectations for the delivery of healthcare, and a huge part of our planning process tries to balance those things. As I will mention later in subsequent items, it's fair to say that the financial position for the NHS in Derby and Derbyshire is significantly challenged. Colleagues who I've worked with over many, many years know that that's not new for Derbyshire. We've worked through financial challenges together previously. However, it is a relatively acute situation in terms of trying to manage all the different aspects that we need to deliver. But we'll be keeping partners updated as we work through that. Since I last reported to the ICP, we've now concluded our staff consultation in the Integrated Care Board itself. We are now working through the final processes of our change management process and are on track to deliver the requirements with regards to the reduction in running cost that have been set out for us. There is an update on industrial action, and colleagues will obviously have seen in the news the settling of a negotiated position with government between consultants, however, ongoing dispute between junior doctors and government in that regard, and I'll obviously keep members updated on that as it plays through the year. You've mentioned Tracy's not with us today, but Tracy has announced that she's stepping down from the role as Chief Exec of Derbyshire Community Health Services, and obviously we'll be supporting the Trust in appointing a successor to Tracy, and something we will need to think about collectively is the approach to leadership at place, given the massive contribution that Tracy has made in that regard, and that's something we'll have a conversation across the ICP around as it's a partnership venture. And then probably lastly, Chair, I'll just pull out, if I can, the changes with regards to specialised commissioning that are underway. We've agreed with NHS England not to take on the delegation of commissioning services for specialised services that were previously done by NHS England. About half of them we're taking forward. The lead ICB for that will be Leicestershire and Rutland ICB, but obviously we'll be working with them to do that. And this next year will be a transition in terms of understanding how we get a population health view of those important services. So I'll probably stop there, Chair, and take any questions. Thank you.
Thank you, Chris. Any questions for Chris? I can't see a raised hand. I mean, I'll say on a couple of things that sort of, yeah, I think we're all conscious of. Budgets, you know, my latest presentation on the DCC budget at Parish Liaison meeting last night, and, you know, we've got a gap of something like 40 million, which, you know, in the scheme of things is perhaps not as much relative. It's difficult when you talk about gaps, but I mean, the challenges, you know, we've got so many ambitions, but, you know, can we deliver them all? And we are going to be hampered by budget, so we know that. The other thing I'd pick up if Tracy had been here, I mean, I know she's not leaving until September, but she will be missed. I mean, she's been an absolute star, so yeah, but no doubt we'll manage to get our formal farewells to Tracy. So nobody's picking up on anything? So, oh, yeah, sorry, Councillor.
Thank you, Chair. I'd note what you said about Leicester and Leicestershire commissioning specialised services, but what are those specialised services?
Sorry, let me put my microphone on through you, Chair, if I may. So there are 59 services that are commissioned by NHS England because they are of a nature of specialist healthcare that it wouldn't be feasible for individual areas to do. There's a process nationally that reports through to Secretary of State that determines and agrees what they are and sets those out nationally. And there are some of those specialised services that are even commissioned once for the whole country because they are that specialised. The ones that we're being delegated, the 59, are ones that are done through the region, NHS England in the Midlands, and we're taking those through. And there's a whole raft of them. I'm happy to bring a summary of them, if that would be useful, and send it through so you get a flavour. But things like specialist kidney services, renal services, would be an example of what they are. But if it's useful, I'm happy to send that through to the ICP, just so you see the list. Would that be useful? Yeah, no problem. I'll take that action. Thank you. Through Lindsay, I'll take that. Thank you, Lindsay. Thank you.
Right. Thank you, Chris. Yes, Alison.
Thank you. Just to thank you for the report, and just to note, I'd also like to congratulate the care home winners in the 2024 Care Awards event in March. This is an event that I think I should know more about. Carol, I don't think I know enough about this, but I think I think we all recognise that care homes and carers do a sterling job. They're often not sufficiently recognised. It's something that we want to work on improving. So we've got these 4 homes in Derby and Derbyshire. Perhaps they're all in Derbyshire, I'm not sure. But it's great that they've had those awards, and I'd just like to add my congratulations here to them. Thank you.
Thank you, Alison. And apologies, I mean, I should have said thank you for chairing the last 2. We do, as you probably know, myself and Alison co-chair this, so it's my turn again this time. So but thank you for co-chairing before. Right, so if there are no more questions on that, can we move on then to the next item, which is the Integrated Care Strategy Theme Focus, and let's start well, and it's over to you, Nicola. Thank you.
Thank you. Thanks, Chair. So to introduce myself, my name's Nikki Smith. I'm the Assistant Director of Children's Strategic Commissioning at the Integrated Care Board. So I'm here today to give an update on the progress of Startwell. So just to take a step back for those who are new today. So Startwell is one of the key priorities within the Integrated Care Strategy, with a focus around the school readiness, which is a public health national indicator for children. So the slide that's up on the screen at the moment, we brought to the partnership previously in terms of where our focus is going to be over the next 12 months. So we've decided to focus on special educational needs, because this is the area where we compare worse to England, and the other area is breastfeeding prevalence, but because of the significant public health focus on that, we've chosen to put our focus into special educational needs. So obviously the links with schools, education, early settings, and social care are absolutely key to this, for us to work together to make a difference. Thank you. So within that indicator, the 3 main areas that flag are autism, autistic spectrum disorder, social, emotional and mental health, and speech and language communication needs. In the very young children, that is our focus. The most significant one is the speech, language and communication needs. Thank you. So I'll just talk through each one separately. Thank you. So in terms of autism, in terms of where we are up to date, so we do have a neurodevelopment program delivery group, that oversees the work that's undertaken. Within that, there's various task and finish groups, and what we're currently looking at is looking at specific outliers in terms of education, where there's significant referrals through to assessments, and using that as the basis on which we start to work with individual education settings. So our next step is that targeted work alongside education. We are working with colleagues. We have the neurodevelopment community hubs established, and we continue to work with partners to develop them and to support hopefully we're looking at doing some triage and pre-screening to support those. So the challenge, as has been alluded to elsewhere, is that we are in the middle of planning. So our challenge is that we can't finalise our plans and move forwards until we come through that process. I think the key thing just to highlight is, you know, the funding and the challenges that we've got doesn't impact on our passion to make a difference. What it does mean is that we have to be really clear and really specific about what we do and the pace at which we can do it is not as fast as we would like it to be. So thank you, that's that one. So the social, emotional and mental health indicator. So our focus to date has really been around older children, and we've been doing some work with schools around sustained absence in children with anxiety and mental health needs. So the good news is that the latest NHS operational plan supports our digital ambition in this area, particularly for younger children, and to do some development around an app and some additional support for families. And we continue to roll out the mental health in schools teams, and that's across, that includes primary schools as well as secondary. So thank you. So the final one, the speech language communication needs. So a transformation board has been set up. It's led by the Allied Health Professional Transformation Lead, who's within the ICB. And that board will be taking what they call a balanced system approach. So across the whole system, we'll be looking at working with partners around making sure that the support that's available isn't just for the children, it's for the staff and the professionals and those that wrap around the children and support them. Thank you. I think that's everything I wanted to say. I'm keen to take any questions.
We'll go at the back then Chris, then Richard. Thank you.
Thank you for the report. In the report for the previous item that was circulated before the meeting, it talks about needing to make quite significant savings to running costs, obviously 30% by the end of the next financial year. What does that mean for the delivery of this priority?
Thank you, yeah. So it does mean, so originally we wanted our scope to be much bigger. We wanted to be working across place in all the alliances across the city and across the county, and that would have taken a significant amount of resource in terms of project management and support to do that. Because the team has got smaller, our ambition to do that hasn't gone away, but what we have said is we can't do all of that in the first year. So in the first year, we're going to really focus on these specific areas, and that SEND indicator, get some really good work and deliver some good outcomes there, and then we can have another look and gradually fulfill the ambition of where we want to go. As I said before, it doesn't take away the passion to do it. It just means the pace at which we can do it is going to have to be a bit slower.
Oh, sorry. Thank you, Nikki. Really appreciate it. I suppose my question is about the framing of this within the ICP and Start Well. And it's probably a question for yourself and Ellie and Robin just to guide us here. So are we saying this is the NHS's contribution? So, I mean, we do a lot in the Start Well space, of course we do, but when we were creating the priorities here, it's about just going further in a priority area. Are we saying this is the NHS's go further area in the Start Well space? Or is this the area the whole partnership has chosen? So it'd be just great. And then if we could just have a bit of confirm and challenge on why this area. I know we might have had that conversation already, but could we just check it? Because there's lots of areas you could, why this one? That'd be really helpful. And just if I may, just to colleagues' point around running costs, you're absolutely right. 30% reduction is significant, and it will have an impact. And the whole purpose of priority now is just crucial to all of us, isn't it, and across the sector. But thank you. Back to you, Chair. Thank you.
Thank you, yeah. So I think there's the recognition that we, as the NHS, are a key partner, and we're the ones that are really driving this forward within the partnership. But if we're going to be successful and if we're going to deliver that change in school readiness, we have to do it together. We can't do it in isolation. So I think that's the piece around, is this just NHS? No, it's not. It needs to be whole system, and it needs to be pathways, but it needs to be joined up and us all working together. In terms of why this priority, so it was chosen because it's the one where we really stand out nationally as an outlier within the school readiness indicators. It's the one that stands out across both city and county. So in a number of indicators, the city and the county score very differently, and sometimes the city is better than national average and the county's worse, and vice versa. So this was the one that really stood out across the whole that we wanted to focus on. So the work is overseen by the Children and Young People's Delivery Board within the Integrated Care System space, and that board is jointly chaired by Carol Camis, who's the designated Children's DCS strategic lead at county, and Andy Smith in the city. So we are, it's not just the NHS that's making this decision in isolation. Thank you.
Thank you, Chair. I'm Richard Wright, the outgoing interim chair of the Integrated Care Board. So obviously 100% of my time's setting up my successor, Kathy, who's on my left. So good luck. I think, Nicola, I'll tell you why, when I was reading this, there were two things that sort of got me. We're talking about school readiness, which by inference means that they're ready for school when they get there, and yet quite a lot of these interventions are when they're at school, which means we've failed, which is, do you understand what I mean? And I thought all this was about intervention before school to prevent all those costly interventions because they hadn't got there. And so I didn't see a lot of that in here, is the one thing. And I just wondered if you've got any thoughts around that. The other thing I thought when I was reading this, and you know, I can understand why we've gone for SEND, because we're an outlier in the wrong way. We're below the national average, and we need to get that back in. But I'm also really interested in not burying ourselves in the pack and doing things that actually really take us forward and set us up as an outlier in the other direction, if you understand me. And I'm just wondering, are there any interventions that we should be considering? Because, you know, I understand that, and it's a fairly specialised area, this SEND bit, but there's a lot of children out there who are not school ready. What's the things that we could do that would really make a difference to a lot of people and put us ahead as well? And I didn't see that in there when we're evaluating where to spend our limited resources. That's the only things I would have asked about this, if I'm being honest. Because I'm really, you know, the objective here is actually to have a sustainable health and well-being system in the future. So we've got to do things that reduce interventions and needs for interventions and hence cost in the future. And it's that return on investment argument. And you can't just do it by picking the outliers, if you understand me. You've got to make a significant difference across the whole patch. And I'm just wondering, have we looked at it in that way properly? I didn't see it in the presentation. Sorry, I hope that's not too awkward.
No, it's fine, no. So with regard to the first part, so yes, I agree, it's school readiness. So we're looking at children in reception as the point where we measure how well we're doing. So when I talk about education, I include early years settings in that. So
okay.
Many children will be within nurseries.
So it's prior to sort of 4 or 5 then?
Yeah, and obviously families. So the work, much of the work that we're doing is around supporting families as well. So the piece around, have we considered the wider things that would make a difference? I think So we're basing it around school readiness, aren't we? So that's the point at which we're focusing. There is absolutely something around the inequalities agenda and where we target and who we target within the scope of what we're doing. I think because we've based it all around school readiness, that's the point that we've used to focus and say, so which are the areas that we stand outside? I mean, it's a really good point. I think there's other wider work that's happening within the Children's Transformation Programme around key priorities within the long-term plan. You know, we have other drivers of focus as well. So this isn't the only thing that we're doing to support these younger children, but this is the one that we've chosen to really focus on to make the difference this year. I think we're just keen to keep the scope small and the impact big, and then we'll move on to the next thing, but it's a good point.
Thank you very much. Thank you, Nikki. Helpful to see this, and it links clearly to the strategy, doesn't it, and those early years. I think my questions were in the same kind of space as some of the ones you've heard. And I'd like to just challenge slightly the linkage with place, because I think you're implying, and I think some of the question was, if you've cut the number of people in the ICB, what impact will this have? Well, I think that's a tiny bit of the resource possible across the system, isn't it? The number of people working with families and children at place, at neighbourhood, and will be huge. And I just wonder how this is going to connect in to the place work. Because I can only see that it must, surely, really, you know, and that expands the number of people and the different sectors involved. And also, I suppose, linked a bit to what Richard was saying is, yes, you've picked these things, and I can see why you might pick those. But to get a child ready for school, they live in a family, they live in some sort of context, don't they? They live in a house, you know, is there employment, bringing in resources, etc. So I just wonder how we're tackling that, or is that a something for the future? But it feels so important that which comes back to the place bit. How do we actually deal with that? And then on outcomes, you have written down some of the things you expect to see, but I would just push further on outcomes. You know, have we got a baseline? What are we actually going to measure? What are we going to see that's different? And how are we going to track that? Because that's often the tricky thing, isn't it? How are we going to really see outcomes move? But I mean, this is such an important, the early years is such an important, 25% of the population are children, 100% of the future, aren't they? So this feels a little narrow to me, I have to say, but it may be the right thing. I'm just coming to it fresh, really. Thank you.
Thank you, thanks. So in terms of connecting with place, I think in my mind, education settings are places. so that's where we look to when we want to make connections with children and families. I absolutely understand and get that we have other priorities within the system who are utilising the place networks that were established, and absolutely we need to be thinking about how we link with them and how we use those connections that are already there to support us with this, and how we make sure that what we do in the community is relevant for that local area and that community. So yes, I agree on that point. So in terms of the future, yeah, I think, and the scope of what we're doing, I think we're in danger of making it too big and not having the impact that we want. So we could look for a wider scope, and we could look to impact on more, but that would mean that it would take us longer, and we are really keen to try and have some impacts as quickly as possible. So I think that's possibly why we're doing it in the way we're doing it, but we can certainly consider doing that differently if that's the feeling of the partnership. And then in terms of the baseline, the measurements and the tracking and the outcomes, so the outcomes are obviously in the longer term around that school readiness indicator, and we should see that movement. In terms of what we measure and what we track, I think, so for some things it will be quite easy, it will be quite quantifiable, that we can count if the things that we put in place are being utilised and are successful. And I think some of it will be the more qualitative aspects as to whether or not they're making a difference and how people feel about what we're putting in place. So I hope that's helpful. Thank you.
I've got Chris, and then I'll listen to Chris.
Thank you, Chair, and thank you, Nicola. For those of you who don't know me, my name is Chris Wine. I'm Chief Medical Officer at Derby and Derbyshire ICB. Look, I'm a huge supporter of work which is focusing on trying to tackle school readiness. Okay? And I think it's really important that we recognise the long-term value of that work. So recently we had some announcements around improvements in GCSE results around children who've been focused in on preschool. If we look to the States, similar work, which is focusing on preschool children, has delivered measurable improvements in mental health, employment opportunities, drug addiction, 18, 20 years down the line. So it's a hugely important public health measure. It is a measure which is delivered at the age of 5 at school entry, which means the intervention needs to be before school entry. And I do then sort of start to say, well, have we got the focus quite right here? And it's one of the things which I'd like people to consider. A few years ago, and some of you will have heard me speak of this in the past, so Professor Michael Marmot was being interviewed on Radio 4 about 7 o'clock in the morning about one of his health inequalities reports. And John Humphreys at that time, right at the end of the interview, suddenly threw in a question to Professor Michael Marmot, which was, if you could do one thing to improve health inequalities and the health of the community, what would you do? Quick as a flash, Michael Marmot responded by saying, I would get parents to read their children a story at bedtime each night. And I do wonder whether there is other stuff which we can be doing in this space to improve readiness for school, to improve health outcomes for those children, not only in the short term, but the long term, that we haven't yet quite considered.
I don't know if there's anything you can answer that. We just say yes, yes, yes.
Yeah, I agree. I've heard you say that before, Chris. Yeah, I think you're right. I think, and we see it quite a lot, don't we? Even with children with the most complex needs, quite often it's the simplest and the most straightforward of things that makes a real difference. And I think there is something about that. Definitely. Thank you.
Chris?
Yeah, thank you. So, first of all, because autism is a focus here, just to declare an interest that I run an autism organisation. Okay, thank you. So, I just want to draw attention to two things in terms of this plan. Is number one, that a few years back, those who were involved and around will remember that there was quite devastating report from CQC in terms of services in Derbyshire and Derby City in terms of neurodivergent children and particularly autism. In fact, it got national publicity. So one of the responses to that was the creation of a neurodevelopment pathway co-production exercise probably one of the best I've seen. I've been involved in those around the world for many years, but one of the best I've seen and the best led. And coming out of that, it was multi-stakeholder, so it was parents, carers, all clinicians, etc. It was, everyone was there shaping what should happen to try and solve this problem. And of course, the issue of hidden disabilities in terms of inequalities came out within those discussions. But I can say that in terms of the hubs that have been placed in there, designed exactly by parents who said exactly what they needed, and there was a lot of feedback within that. But a key thing was age 0, so pregnancy up to, whereas it may have started a bit later than that, the initial discussions with that. It was then shaped to pregnancy when someone gets something flagged in a scan, right up to 25. It was originally 16, but that was extended to 25 because of transition, the importance of that. So that was one thing, just those 2 points I wanted to stress. And the fact that readiness for neurodivergent children, which is over 50 different conditions at least, not just autism. Autism comes up the most across all the strategic groups that I'm in across the system as a significant problem. But those children, of course, all children grow at different stages, and the points made about preschool are well taken, and especially in low-income settings, which we've heard Chris describe before, the importance of that. But so too are communities of interest, so too are condition-based communities, not just autism. So those don't tend to get looked at as much because it's a bit of a grey area against income, for example. So I think that these children are developing at a different rate. So as you go through each stage of development, so aspects of your condition become more apparent and are a barrier to you. So we work a lot with certainly autistic children, and it would be a huge benefit that they're worked with prior to school. And that does happen, and the NeuroHubs have opened up a whole range of opportunities for children preschool to get support. That is certain, and about a third to 40% of those attending are prior to school. Okay, the parents. But I think we'd have to be careful of not thinking that it's important in school. And I did raise this point in Matlock, when we had the recent discussions on Startwell and school readiness. That readiness applies to the schools as well as to the children in neurodivergence particularly. And so whilst I respect absolutely these views put forward, I just wanted to put forward that factual information and view. Thank you.
Alison and then Ellie. Yeah, Alison.
Thank you, Chair. I did attend the Derby Health and Wellbeing Board, Scrutiny Board last night, and we had a presentation about the NeuroHubs, etc., which was very informative and well received. And I've taken away about 3 or 4 actions from that meeting, actually, as it happens, to look at promote opportunities for autistic people is the preferred term in Derbyshire, apparently, within the council and also within the leisure service, etc. So there's no doubt that it is extremely important. I suppose in terms of the general approach, I guess I would, without for one moment detracting from this agenda, I suppose I would, when you look at the big interventions that have happened in public health, whether it's vaccinations or whatever, or no doubt you can all give loads of examples far better than I, they do tend to be a bit universalist, if in policy, if not always in absolute delivery. So to that extent, I would echo some of the things that Richard was saying. But I think, Chair, I think there might be an issue here for us to discuss, or and also with the Vice Chair, about the process here, because we agreed that there would be a Startwell. Everybody agreed that there'd be a Startwell focus, didn't we, as part of the a school readiness focus within the Startwell agenda. That was agreed. And so now we have a proposal here, but I think maybe we need to have a think about how we make these decisions, in the sense that there's clearly some disquiet, if not rejection, about the proposal for this focus. And maybe instead of having a whole piece of work that has assumed that it will be the next level of focus or the specific area of focus, you know, we should perhaps, I'm putting this up for discussion, Carol, this isn't a suggestion. I mean, maybe what we should have been doing is actually getting a series of proposals for where the next process would be, and so that everybody could then buy into that before that is decided by your board, but guided by the board, obviously, because you are the expert. So that's what I'm wondering. Thank you.
We'll certainly look at that, Alison. We'll have a conversation following on then for the next meeting. Yeah. Right, it was Ellie, and then at the back. Thank you.
Start with. There we go. So I just wanted to pick up on some of the points people have made and just reflect back on a conversation that we had when the strategy was launched about what the purpose of the strategy was going to be. And I think what we talked about was different parts of this kind of work happening in different parts of the system. So the health and wellbeing board's looking at the wider determinants angle, this partnership looking at the opportunities for integration and to test out areas to work together on. And I think this does that really nicely, actually. I think there are areas here where we're talking about an integrated multi-agency approach to some challenging issues. And whilst I recognise that whenever we get into the conversation about prioritisation, there's always going to be competing priorities. We have challenged ourselves, I think, over the last few months to say what is the one thing, and I think that was a challenge to you, and you've come back with this is the thing. We're talking about a relatively short period of time here, aren't we? So we're talking about over the next 12 months, we're going to focus on this and look at how we can better integrate to tackle something where we perform more poorly than our comparators across both city and county. And I think, personally, I would support this as a proposal and a way forward. So I just wanted to add that in, because I think if you go to look at the Health and Wellbeing Board strategy that we've just signed off in the county, then that has got a focus on school readiness as well. So building out from here, perhaps it would be helpful for this board if we could tell that story about how this work dovetails into other work that is happening on this agenda, so that people can see the whole picture, because I think maybe that's what's missing. It's not that it's not there, but perhaps it's not visible here. Thank you, Chair.
Well, hello everyone, my name is Jackie Willis. I'm standing in for Kim Harper today. I'm Chief Executive of Derbyshire Voluntary Action. So really encouraging to hear that, you know, the social, emotional and mental health of our earliest and youngest children is really important. I suppose my plea is just social connectedness. So the social, you know, not to sort of forget that importance of social connectedness and all those lovely things that you learn, the boundaries that you learn before you get into school to make you ready for school. And also, I guess, obviously coming from the voluntary community sector, I'm going to put a plea out there that we've got lots of voluntary community hubs across the county and city, and we've now a new network of those community hubs that was launched yesterday. So we're sharing and learning network across county and city. And, you know, if we are strapped for cash, as we know we will be, then, you know, and we want a multi-agency approach, then let's please make sure that in the same way that we've been really successful with the neuro hubs, let's think about assets that we've already got in community and help and support them at very low cost to actually bring all those things in to help and support. As an infrastructure organisation, we work really closely with our local play centres and play groups. And actually, you know, there's so much we can do there that would fit in and be part of the work that you're doing. So just a plea to have some conversations, maybe. Thank you.
Sorry, I was just really struck by Councillor Martin's point there. I think we're missing a step. So I think we need to see the workings of the Children Delivery Board, that looked at the options and a recommendation is made to the ICP on this being the priority. I think that's the step we've missed. It. That's clearly been done, but I think that's what Councillor Martin's referred to, and I think it's right that we see just the recommendations, the options appraisal. We've looked at this, this and this, and on the balance, this is the priority area. I think that would land well. So, I'm fully supportive of the decision you made. I just think there's a process step for us to just conclude. Thank you.
Yes, thank you, Chair. So I thought Ellie's input was really valuable, actually, in pointing us to the fact that this is a time-limited intervention, time-limited focus. So I think we should bear that in mind. I think Chris's intervention just now very important. Actually, there is working there in the background. It'd be useful to expose that working, but also for us to recognise, I think, that there's the opportunity for us to, when there is a refresh of what we're doing in the Startwell space, to go back and say, right, okay, what are the big things that we want to do as a system here, and to relook at that question again at that stage.
I can't see any more hands, so if a lot of reaction and a lot of sort of, and I think we're sort of wanting to focus in more things. Just one or two of the things that I picked up on it, listened to it. I think that it's part and parcel where there's good partnership working with the city and the county, because there's lots of things that we can feed into that. One of my concerns when you were talking about special educational needs, I had occasion to go to a school in Petersham, Breckenfield, and they're doing fantastic work, but they had one place, and I think there were 80 applications to fill the one place. I mean, there just isn't enough, enough spaces, and that is worrying. And going back to what Chris said, my great niece was a primary school teacher, and she said she can't believe the children that actually go to school that are not even potty trained and things. She is, I'd love to bring her, I brag about her, but I mean, she's an example that she is, she is reading stories, she's working with her little girl, she's 6 now, she works with her and really encourages her, but there are so many that don't, and I think it's just how we make sure that, people start and parents start to, lots of good parents, don't get me wrong, but think that, we need to get that message. So important when they're young, as you say, start them off right, and yeah. So thank you, Nicola, that was excellent, thank you, and we note all the remarks, and I'm sure there'll be some more conversations following on from your presentation, so thank you. So we'll go on to the next one, which is Prevention and Health Inequalities Board, and including terms of reference. So I'm not quite sure who's going to take the lead in this, whether it's Ellie, Chris, Robin, who's volunteering.
I think I didn't step back quickly enough there, did I? Okay, so this is just a report that we said we would bring back to the board, having established the Prevention and Health Inequalities Board. So people remember back in October we agreed that we would establish this board and that it would play a role in coordinating, overseeing prevention and health inequalities work across the system, which there used to be a prevention board in kind of days gone by, but that was stopped, and then we didn't have anything that was bringing these specific agendas together. So there's lots of work going on. We recognise there's lots of good things happening across the system, but it is quite hard to have that visibility and to also be able to accurately report back to NHS England and colleagues about exactly what we are doing and where the gaps are. So we had our inaugural meeting earlier in the month, and we have worked our way through the terms of reference, and we brought those back today for endorsement agreement by this partnership as we agreed in the original meeting. Thank you.
Any questions or any observations? Are we all happy with the terms of reference? Yes? No queries, so that seems to have gone. But it's another board and another acronym, and honestly, it's trying to keep up with all of the different boards. But yeah, it's a well-attended board and some top people, and including the terms of reference and governance. So Right, so if we can then move on to understanding population priorities insight framework. Have we got a trio or all three? You're very welcome. I think you're all coming to join us up front. So, Richard, did you want to say something?
Yeah, I'll start this off, seeing as I'm the sponsor. I'm glad we're slightly ahead of time, Chair, because this might just take slightly longer than 20 minutes, if I'm being honest. I'm looking at the girls saying you've got a bit longer than you thought. I asked this to come to the Integrated Care Partnership. As part of my sort of things I do in the ICB, I chair the Public Partnership Committee and I chair the Public Health and Strategic Commissioning Committee, which is, you know, it's really wonderful for me because actually the interesting thing is what I'm trying to assure ourselves is that we're capturing the population view, its priorities, how it's thinking, that we're actually properly analysing all the different views that we get and getting a sort of single joined up message in a way, and that then we're actually properly taking that view and building it into our, you know, the services we commission and the, you know, the plans we're making both short term and long term, which is the crux of it all actually, funny enough, which we're all about. As part of that, Andrea came along to the Public Partnership Committee and presented what you're going to hear about now, which is the Insight Framework, which is a way, which I thought was a pretty impressive way of understanding quite population needs right down at, you know, right down to the coalface, so to speak, to pick up an old industrial term. But as we talked about it, it became quite fair that, you know, when you look across the system, when you start putting it outside the ICB and into the wider system, there's a lot of people doing variations of lots of things in this. And, you know, I'm sort of a big believer of one population, one view, as much as we can, so that we're all aligned around the same objectives. And we, you know, I'm often talking about joint strategic needs assessments and things, messages coming from public health data and all of, and of course, when you take the population view, you've got to combine it with the public health data before you actually commission your services and everything else. It's you've got to put both in there. So I thought it'd be a really good idea if Andrea, and she's brought two colleagues with her, came along and presented Insight, because I thought it was pretty impressive, but maybe as much to prompt a debate about, okay, as a wider system, how do we make sure that we're properly combining resources, we're not duplicating, we're not stepping across each other, we get ourselves to a single joined up way of understanding our population. Now, I know there are different views across the population, but we need to understand that as well, if you understand me. So that's the whole purpose of this. A, it's the presentation, but B, it's the debate afterwards about, you know, how could we make sure that as a system now, we're joined up on this, because resources are tight. We can't afford to, and we shouldn't waste effort if we can possibly do so. We shouldn't duplicate. I hope that's okay. I'm now going to hand over to Andrea. She knows that's what this is all about, so she's designed it around it because we've spoken. So, Andrea, all yours.
Thank you. With that introduction, then over to you.
Terrified.
No pressure, of course.
Oh, okay. I work in the engagement team in the ICB, so I'm an engagement specialist. But really, my background is in the voluntary and community sector. So I probably bring quite a range of experience to this, and it's great to see friends and colleagues at the back of the room there who are very familiar with this work. I'm joined today by Gail and Liz, and I felt it was really important that the people who are doing this work in our communities are here and talking firsthand rather than me telling their stories. So I'm going to talk very briefly. Thank you for the next slide. As we know, our aim is putting people at the heart of our strategies and plans, and that's very well documented within our strategies and plans. The Insight framework is really about how we do that. and how we build meaningful relationships with people, how we build reciprocal relationships that don't just harvest data and people's knowledge and experience, but it's meaningful, it's long-lasting, and we care about people as we go about that work. So it's about how we involve people in their care, how we listen and learn about people's experiences and then turn that into informed action. Crucially, it's about sharing power and enabling social action, and we've spent the past year really exploring what does that mean, what do we understand by our own power, particularly when we're in positions of authority, and how does that feel to people who are citizens or patients or communities. And equally, how do very mobilised communities such as Hartington, where Liz is from, how do they break through the barriers that are around to connect with the system and to get support for the work that they're doing in a very authentic way? And also, how do we make sure that citizens and communities feel that they own their health and well-being and have a real kind of strong and active part to play in that? So I know that the Insight Framework was championed by the Integrated Place Executive, and unfortunately Tracy's not here today, but she has been a huge supporter of this, and Kate, and thank you for all of that, and that's ongoing. And as Richard said, we report into the Public Partnership Committee, which receives quarterly kind of progress reports on this area, and we're becoming more structured in how we're theming the insights, but it's still quite early days. So we're still kind of working out how to structure that and how to feed in and make sense of what we're noticing in communities so that it then informs decisions. So we're not there yet, but we are making good progress. Thank you. So, as detailed in the paper, we invited expressions of interest for anybody across the system who was involved in work that was around kind of getting insights, working with communities and wanting to work in a different way with people. We had around 18 initiatives that were proposed, and we now have 27 which are live across the county and city. And they're really broad and varied, and they're led by different people from different parts of the system, and I think it's a really great example of integrated care happening in real life. Some of that work is themed. So, for example, there's work going on around sexual health, falls prevention, young people's mental health, tobacco dependency, digital access, and the discharge pathway, to name but a few. And then there is community-led work, which is very much neighbourhood or smaller, or slightly larger. So I would say communities of probably between 300 and 3,000, where people have come together and are really taking ownership of their own insight and what to do with that, and how they can manage their resources in a place and do that for the good of the people. And that is really also about tackling health inequalities led by citizens. And that's happening in Barrow Hill, Heanor and Hartington. And there are other places, but they're not quite on map yet. So I'm going to hand over to the people who are actually doing this work. Gail is going to talk about what's happening in Ripley Medical Centre, and then Liz is going to talk about the work in Hartington.
Hello everybody, my name is Gail Bird, I'm Practice Manager for Ripley Medical Centre, and thank you for the opportunity for me to speak about my best part of the job, which is the Patient Participation Group, or the PPG. I'm just going to give you a quick background because it's all relative to the development of the PPG. The Ripley Medical Centre is part of DCHS Trust, and I joined the Trust in December 2022, having spent 23 years for Nottingham University Hospitals in secondary care. I walked into Ripley Medical Centre and immediately, coming from a large trust, going to another large trust, albeit into a small practice, I found it quite unusual. There was quite a dominant approach at the use of power through hierarchy. There was quite a clear divide within the team of the thinkers and the doers, and no real feeling of a shared purpose. And I think this explained the culture within the practice of staff talking to each other about each other. So it was quite soon that I had some indirect feedback that people from secondary care don't last in primary care, they just don't get it. And I agreed to a certain extent. I didn't get Ripley Medical Centre. I did see things differently. For example, the practice was quite steeped in paper-driven processes and habitual ways of people doing things because they've always done it that way and they were comfortable with that. And I did change a lot. I was guilty of that. Some of the quick fixes, for example, were there was a really high DNA rate amongst patients. So I asked the team, do we send out appointment reminders? And the response was, well, no, because the patient needs to take responsibility. They need to write it on a calendar, for example. So it sort of explained the feeling I was getting that the patients were lucky to have us. And while it was very easy for me to switch on the appointment reminders, because I enjoy technology, when patients started to receive 2 appointment reminders, the DNA rate decreased. So I did change things because things had to be done. And I tried to take the team with me, but before long I started to get the feeling that I was disrupting the practice and I was also almost pushed out to the edge. And even trying to encourage staff to come along with me on this change journey, I got the feeling that some people still wanted to be directed. So there's lots of things happening, but then being on the, or I call it being on the periphery, automatically I started to look outward. And then 3 things happened that changed everything. So number 1, I met the PCN practice managers and I joined a meeting every month and they just welcomed me with open arms. They didn't see that I was any different just because I'd got a secondary care background. And although there was always a formal agenda, we had time to talk to each other and listen. So that was one positive. The second thing, and probably the best for me, is I met the PPG, all 2 of them, hence the tumbleweed. So we met, I listened, they talked a lot, and we just connected. So our next meeting, we decided we would go along and join on Teams for the JUCD PPG network. And it's from there we got our inspiration. We looked at what other practices were doing. We decided to meet the next month and we'd just think about brainstorming how we could increase the membership of the PPG from 2. So we did, we met, we went off-site, we met, and our ideas were big. We talked about things such as, it sounds daft now, but like a video drone that would go around the practice, and we'd put that on our website, some sort of banner that would be running, and we'd have people flocking. We'd put out some really good strap lines, and we'd get people to join. In reality, we didn't have the money, so I suggested that on the back of the reminders for appointments, that we sent out a friends and family feedback questionnaire, but I would also put a question in there, would you like to join the PPG? And just give us your phone number. So there was nothing that could identify patients, it was anonymous. And I gave those phone numbers to the PPG chairperson and they would ring the patients up, and gradually our membership increased. So that was in August. We're now in April and we've got 30 members and 15 regular attenders each month. So that's when, if the next slide, at one of our meetings, somebody said we're going to need a bigger boat. So we outgrew our staff room. We've now progressed to the waiting room. And it is such a highly motivated group of people, it's taken me by surprise. We've got a very diverse group, we've got younger members and the older members, but what we do is we talk a lot and we just have great ideas. But one thing that's come through, which is a theme, is that the members are really keen on taking responsibility for their own care. They want to be involved in that. So it's changing the perception of how the practice tries to solve problems, really, and it's opening up to the community. One of the other things that they're very keen on was about gaining information. So they started asking about acronyms such as PCN, ARCH, ICB, ICS, ICP, and all that which I wouldn't expect them to ask. It was quite clear from the new group that they wanted more information and they wanted to be involved. So even now we talk about what does the future hold? How do we even start to work with the PCN and our neighbourhood practices? So it's things that they're bringing up is starting to surprise me, but it's really welcome. One thing that I did ask them, for example, was, would you like to get involved in, for example, a diabetes education evening? And they said, no, absolutely not, because we are the experts on that, those people with diabetes, but we would like a shared network, a forum where we could meet and talk. So all the perceptions that they're raising, all the ideas are different, but valid. And then the third thing that happened that was inspirational for me was to be part of the community-led Insight pilot, and that arrived at just the right time last year when I was trying to develop the PPG. And it's through those network meetings that I attend, it's the information that I take back, and just having an opportunity for others to listen to me, but also gain knowledge from their own experience has been invaluable. And I thank Andrea for that. So the toolkit that's in used has helped me with reflection and planning, and it's a visual that I use to see how things are developing over time. But I think most importantly, the groups help me to be brave and encourage me to just go out there and do what I think is right for the community. So reflecting, 3 things that I've spoken about, the PCN Practice Managers Forum, the PPG and the Community Insight Pilot, the three things that they all had in common was networking and basically the power to transform through building those important relationships. When I look back at the progress we've made, it's quite phenomenal. And for the practice now, where are we? Well, things have improved. There is still very much power through hierarchy. But, you know, I've nudged my way in and I'm sharing my approach of getting people to connect with each other and taking responsibility rather than using those people within the practice use positional status to try and find solutions to every problem, because that's impossible. So people are starting to put their hearts and minds into their jobs, and the feedback we're receiving from our patients is brilliant. We are getting a healthy 90% rating that the practice is very good, or good.
Thanks, Gail. Liz, over to you.
Okay. Yes, Hartington, if you don't know where it is, it's about 10 miles south of Buxton, and a really good place to live. So our story, begins with people. We are a very rural community, approximately 300. We just about meet Andrea's benchmark, I think. What we are is very people-rich. We are such a wide range of skills and a massive variety of backgrounds that the people come from. We are significantly digitally poor, which actually for me isn't a problem at all. I don't think it's always a bad thing. It makes you what we are, which is we have a real proactive community, a very resourceful community, and it's absolutely driven by need. This actually then developed, it was 2012, when a body called Hartington Community Group was, it became into being. And it came into being because we had a need. As a community, we wanted to celebrate the 2012 Queen's Jubilee. And so, as a community, we got together. We had no cohesion before that, but it brought us all together. And that group now has grown into a umbrella constituted group, I think that's what I call it. And it supports approximately 20 smaller groups which are providing physical activity and social opportunities in the heartbeat of our village. And that's the place. Now, our place is Hartington Village Hall. It was built 100 years ago. It was left in trust to the community. It's a registered charity and coordinated by trustees and management, all of which are members of our community. The importance and relevance of this place to the community is demonstrated when, in 2017, crisis arose. And this was recognised in the fact that the hall was nearly bankrupt and in a very poor state of maintenance. An emergency meeting was called, and half the population attended, and resulted in volunteers standing up and saying, never had been in their lives a trustee before or on a management group. We've got to keep this place going. We'll stand up and we'll do it. And this enabled the community to work together to raise funds, use their skills, and I'm talking about practical skills here, to restore the hall to the vibrant place it is. And it's home to the community activity throughout the week and many weekends. Now, how does this apply to what we're talking about today? What it is, these people and this place have now learnt through respect and trust for each other, and that takes a lot of time, doesn't happen overnight. It enabled people to come together with confidence to share their needs, listening, learning, and make it happen with them and not for them. So the activities and opportunities, how do we know what these needs were? And listening to particularly the work about the preschool children, we've not got a lot of preschool children, but we established a Wriggles and Giggles Club, which was for parents and their preschool children. We listened carefully to what their needs were. We had established clubs for young people who are still at school, listened to what their needs were. The adults, the elderly, and we have determined with them, not in a room on our own, with them, their priorities and the next steps to support their physical, mental and emotional well-being. A really good example of this, and this is because of the work that Andrew has done and helped me, not just me, our community with this insight work. We actually were able to present at one of our rural social groups once a month on a Tuesday afternoon, ample amount of tea and cake, which is the reason that they come, I'm quite sure. But there we had a falls prevention service advisor who presented at this occasion. And it was part of the Hartington Alive presentation or project, which is running because of Insight. Over tea and cake in a relaxed and an informal setting, many members came to find out more and have now signed up to Live Stronger for Longer classes, supported by Age UK and the ICB. Also, a local person is undergoing training so that she can continue those classes when the tutor and Age UK have left us. So impact, sustainability, positive outcomes, all because it was led by the community. So taking a leaf out of Gail's book here, instead of busily rushing on, and as our habit of doing, our learning, our reflection really reinforced that we are all responsible to ensure we respect and trust each other. And this will only be done by building relationships between the communities and the health service specialists and the providers. We have much in common. We absolutely passionately believe and have a desire to help people live healthier lives, reducing the need for hospitalisation. However, we do work differently, just as Gail has been explaining. My perception, right or wrong, is that the way that the service providers, health service providers work is that they have to be in a structured environment. They seem to be very process-led. But most importantly, they are the guardians of the knowledge. You are the people that have that knowledge and understanding of what will help the community. Communities, well, we're very needs-led. We are very flexible. We understand the importance of the knowledge and the information, but of course we don't have access to that content, and nor should we. But we need it to be delivered in a safe environment, in a language that they understand, because knowledge is most definitely, as you know, power. So here we are, communities, national health service providers, and we both need each other equally. We both need to expect and understand each other equally. We can facilitate what you want to deliver. And I'm really convinced of that. This is a model I appreciate in a small rural environment, but the principles that underpin it can be applied anywhere. Thank you for listening.
Thank you both. Okay, so in wrapping up, clearly there is much work going on across the county, and these are just two examples. We're involved with development of the CQC framework to measure performance of ICSs in relation to their people and communities, and Derbyshire has been selected as an example of good practice. So we're working on that at the moment. We're trying to mobilise as many different initiatives to develop broad learning, and always trying to create feedback loops to involve communities and the people that we're working alongside. And we're trying also to build capacity for this work, because nobody can do it on their own. So there's various training going on at the moment. I think the purpose of this paper was to raise awareness of the work going on around culture change, to work with people and communities and how that's happening, but also looking for support to drive this agenda from the heart of the integrated care system, which is why it's here today. Thank you.
Thank you, Andrea. Right, any questions? Yes, David. Thanks, Jackie.
Hi. It's not particularly a question. I suppose it's more of a comment, if that's okay, Chair. Just to say that we're, you know, as VCS reps, and I don't know if I speak for you, I've just been having a little sort of conversation with Wim, but we're really grateful that the tool is a simple way, I think, of defining something that we've been doing in the voluntary community sector for many years. The way that we tell our stories, the way that we involve people in the design of all our services, because that's where voluntary community sector services come from. It comes from a group of people, generally in community, that see a need, and as you do have done in Hartington for many years, you've actually developed that need, and now there's a way of you now showcasing what you do and how then you interact with other parts of the system. So for me, that's, you know, that's a really positive thing. So I'm not saying anything negative about the tool at all. It is a very simple way. It's a very good way for some of our smaller groups as well to understand how they can fit into showcasing the value of and diversity of what they do. I suppose my plea is that how do we get that so that more people can use it in our voluntary community sector? And how does it then work with the support that the infrastructure and other organisations are doing in communities? Things like feeling connected and social connectedness, in, you know, things like that we're doing and working with the district councils, things that are happening at that very neighbourhood level. So I suppose it's just that, you know, it's fabulous, but can it be owned a bit more by the sector as well as the system? I feel like sometimes we're a little bit out of the system with it. And I think it's down to capacity and time for not everyone can engage and not everyone possibly should engage and they'll do it if they need to and want to. But I'm rambling now. I just think that it's nice it'd be nice, I want it to feel owned by more community groups as well. And I understand absolutely that it's helped in the primary care network, you know, in the practice, that's fabulous. And it can help in any organisation or situation because it's the principles of what we all want to do and how we engage with our communities. And I'm rambling, I know, a little bit again now. It's happening, and it's happening in a lot of places, I suppose. And then it is a natural thing, but it's great if it helps to pull it further into the system and for our boards and our statutory organisations to see that diversity we've always been trying to shout about. I'll stop there. Thank you.
Thanks, Jackie. And yes, you know, that the short answer is yes, and that's why we're here. You know, the work only really started properly last summer, and we had to start somewhere, so we started where the energy was and through the expressions of intent. Yeah. The principle is that this is embedded right across the system and owned by everybody. No one element of the system could or should own this, so I totally agree.
Thank you. Yeah, I agreed. So I'd worked with quite a long time with... sorry, I thought I'd pressed... Sorry, do I have to do anything different?
That's the one, sorry. I won't repeat that bit, but first of all, thank you. I thought it was a fantastic presentation and really powerful and really empowering to hear that and really quite exciting about the work that's taking place. And it was really pleasing to see that sort of general practice and PCNs are both connected into that. And I'd really like to sort of reach out outside of the meeting and help build some of those connections more widely into some of the fora that we have across Derby and Derbyshire that support general practice and PCN. So I'd really like to do that. The other point to make was around the latest guidance, planning documentation around PCNs, puts PCNs back in that realms of sort of focusing on improving health outcomes and collaborating with communities. So it really fits into what you've been saying. So I'd really like to lean into that. So it was just to make those points, and we'll perhaps connect after the meeting, but thank you.
Sorry about that. So, so first of all, I did many years work with New Economic Foundation around this, as what makes communities, some communities thrive and some communities sink. They were looking at communities of place. And one of the most striking things with that action research with East Midlands Development Agency, at the time it was about £8 million, that it really just came down to controlling and releasing at the end of the day. So the more you open the space for communities of interest or communities of place to solve their own problems, and not interfered, but made the enabling environment easier for them to succeed, there were tremendous results, and that those were more likely to be sustainable. So Andrew will remember our discussions in Amber Valley about this, but so this model is doing exactly that. It's allowing people to think and release action. And you'll recall in previous meetings here how we've discussed the importance of local assets and the importance of releasing local assets in doing solutions, and how this is written into the voluntary sector and the it's actually the JUCD MOU of working practices that has been agreed here at this group. And an important issue is this issue of releasing change in behaviours to start releasing and listening. So that's that. It really works, but obviously it's got to be a practice that's adopted exactly as shared across the board. It's not hard to learn, but it does need to be accepted that there needs to be a change, and it needs to be learned, as Andrea touched on about training and, having the capacity to train. So, yeah, absolutely commend that we change to this releasing approach and accepted that from governance, there's got to be areas that are controlled. Okay, but the more we can release, the more we're going to be sustainable with such big budget cuts. Thank you.
Thank you then, Chris. So Alison, and then Cassie, and then Chris. Yes, and Helen.
Thank you. I think it is appropriate to, at this point, with the comment I'm about to make, to acknowledge that I forgot to say that I am Councillor Alison Martin previously. I'm the Cabinet Member for Health and Adult Care here in Derby, and I'm also the co-chair of this board of the ICP and this partnership. And I suppose I want to say it was a very interesting and engaging and positive contribution, the whole presentation, so thank you very much. And so the reason for my mention of my name, Liz, is because I think, I can't think of anybody really who's got any vague interest in Derbyshire who's not been to Hartington. I would imagine there's not. Harting is not just a place. It really is a place. I mean, it's in Derbyshire, and so any time that you feel that you need to, have somebody from Derby come along and some field work and come and tell them and offer them tea and cake to learn more about what you're doing, I'd be very happy to come along. Thank you.
Thank you, Alison. Cassie.
Thank you. I mean, I think this is great to hear about and great. I've had a look at the tool as well. I think it's really good to develop things that can be spread and others can do. And there's a couple of things. One, just linking to the, you've got some things around a GP practice and so on, but the community element as well. And I think that this provides, doesn't it, the sort of base on which communities can self-help, and the things that they raise, how do those then become the things that we listen to and we take action on? And I think it's really good, but I would like to think this is also part of this, ensuring that we're not doing anything top-down, we're actually listening up, and it actually comes up and it just determines how we provide our approach as a whole team. And then the other bit is, it would be good to think that, for example, in some of Alison's bit of the world, in some of Derby City, and perhaps in some other parts of the county, which are perhaps at the more, poorer, more inequitous areas, that we have the same kind of approach. Because there, again, where I've seen communities really make a difference, it's where they've taken control of it themselves and they've said, these are the things we need to do. Then you can link in with the voluntary sector and others who will make the difference. But having a mechanism, I think, is great. And I'd like to sort of see this, really, really move forward overall. And I think there's things you could teach other systems on this. I think there's a spread. I have an interest to show. Not only do I chair the Nottingham and Nottinghamshire Integrated Care Board, but I now, as Carol pointed out to me earlier today, has been announced, sort of today's, it was announced before, but there was something today, reminds us that I'm now chairing also the Integrated Care System Network Board for Confederation. So there is an opportunity through that, I think, to do more sharing and learning. But this seems to be a good thing that we could perhaps link up around and do more on that. So, yeah, very positive.
Thank you, Cassie. We've got Chris, and then Helen, and then Richie.
Okay, thank you, Chair, and thank you for the presentation. Look, you asked for support for this approach, and you've got my support for this approach. And the reason I'm lending that support here is because actually this is absolutely critical to us being able to deliver on things like the health inequalities agenda and the prevention agenda. I'm very, very good at designing services for white middle-class males who in middle age. I'm not so good at reaching out to some of the other parts of our community. I'm not even very good at designing services for my teenage children, so I think we just need to recognise that. So you've got my support. This is absolutely essential, and I think the question I've then got back to you is, so how can you help with the Population Health and Inequalities Board in terms of helping us move forward the agenda that we've got in that space?
Thanks, Chris. I did think at the last item that this work probably feeds really nicely into the prevention board, and certainly keen to talk about how we create the mechanisms for the insights that are coming from here and from Derby and from Chesterfield and all parts of the county, very, very different communities who are using this model. So there's a lot that's emerging from this, and it needs to go somewhere, and it needs to be driven by people right across the system, not just the people who are working at the grassroots. So really welcome your support and keen to find a way to make sense of what we're hearing and the relationships that are being built. Thank you.
Just before I go to Helen and Richard, you wanted to come in about the board, actually.
It actually wasn't particularly about the board. It was about the point that Gail made, and picking up on your point, Andrea, about the need to sort of systematise and drive this at all levels. And it was the point you made about when you first started in the practice, feeling that the practice ethos was almost, they're lucky to have us, and flipping that round. And that being a really good indication of the fact that although we've got a system ambition around this and a shared view that we've agreed strategically, there will still be multiple cultures within our system, won't there, where different bits of the system view this differently. And I think it's a real question for us and a challenge, and certainly something I think we could discuss at the Prevention and Health and Equalities Board about how we really embed and drive this within the system, how we find those champions and maximise the use of those champions and recognise the real importance of this in generating that insight that will help us better meet the needs of our communities.
Thank you, Ellie. Helen.
Yeah, quite a few people have just picked up on a few of the things I wanted to say. I suppose as Chief Executive of Health Watch Derbyshire, if I wasn't kind of completely 100% behind this, then there'd be something wrong. And it's a fabulous tool. It really describes the opportunity, and the case studies that we've heard today, you know, really kind of shine a light on the opportunities and the action that this can have. I think for me, and Andrew, you just kind of hit the nail on the head for me just with a few moments ago with one of your comments about sort of a process behind this now, and in terms of what that really is going to look and feel like, so people can see that in action, particularly when you add in some of the layers of complexity like poverty and disadvantage and people that are living chaotic lives, and then you add those complexities into the mix, and then how does that work through a process that sits under this tool. I suppose another point would be the feedback people give, and the challenge isn't what the system wants to hear, because that happens, you know, the feedback, the voices, the insight sometimes can land and it not be what the system was expecting. And I suppose for me, the process, starting to work through some of those, given some of the case studies that you've got, some of the momentum that you've got, you know, through the examples today, it will be brilliant to move some of this stuff forward, I see, in terms of some of those added kind of bits of complexity. And I suppose it's the utilising it bit. How do we know this makes a difference? What will a difference look like? If we're sitting here in a year's time, speaking back, reporting back to our communities and saying, what does that actually look and feel like if we were going to describe this to members of our community in a year, to say this is the actual impact this has had, this is what it looks and feels like when you add those different bits of complexity potentially that I've just referred to. And I know that this is our bread and butter, so I know this is really hard and really challenging. The tool is fabulous and will be a great way to unpick some of that stuff. And obviously look forward to working with you on the process behind it in any way that we can, as I know we're really connected in with this. So thank you for everything that you're doing.
Thank you, Helen. Agree with everything, and I think creating the conditions for us all to hear and take seriously people's views and then do something with it is such an important part of the work.
Thanks, Chair. Thanks, you three. Really good. Thank you. I suppose I want to ask, really, sort of make comments as like we're now the ICP partnership board, so to speak. Bring it back there. I'm really grateful for everybody's comments, favourable comments. When Andrew came along and presented to me, I thought it was a pretty good tool, actually. I thought, wait, this is where we get to the granularity we need in understanding the population, right? So I thought that was really good. That against, I didn't want to be so arrogant to come along and say, this is brilliant, we should all do it today, because at the end of the day, I suspect, Carol, within Derbyshire, you're doing some of this. Alison, you'll be doing some of it within Derby, and I know the voluntary sector do some of it as well. So that wasn't the purpose of, oh, isn't this great, blah, blah, blah. I do think it is great, by the way. But I think the bigger picture here for now is to ask is, right, how do we, if we think this is good or whatever, somebody needs to be taking this now and saying, right, this is what's happening here, 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 and here. Okay, here's the strengths of this, here's the strengths of this, here's the strengths of this, here's the strengths of this. How do we join this up and stop doing some things in some cases, because we haven't got finite resources and we don't want to be duplicating. How do we get a single way of making sure we get the voice of the population in the right way, at the right level, and feeding it into the things that we do? And I think that's my plea, really, from us as an ICP, and taking the point about, right, a year from now, well, before that, I hope, somebody comes and says, right, this is how we're going to do it as a system, this is how we're going to capture the population's voice, it's either going to be built, I hope it's going to be partly built on the insight work, and that, obviously, and things like that. And this is how we evaluate that, and this is how we feed it back in, which I think was your point, into everything we do, and how we actually do affect those plans, and then how do we feed it back to the community that this is what we've done, so they understand that they weren't just talking fresh air and nobody was listening, if you understand me. And I think that's where we've got to sort of focus now as the ICP, ICS in this now. So I know that isn't going to be answered today, but I think it is something that maybe we should take offline and say, right, how are we going to do this? Let's get a mixture of the relevant people that are doing things in all these places together and decide, right, how we take this forward as a joined-up approach. Because I don't think I want this to get lost, because it's brilliant. Do you understand what I mean? There again, I don't want everybody going off and doing different things and is not having a joined-up approach. Is that okay? I suppose I'm challenging there, really, yeah. But I think that's what we should be challenging too.
It's similar to the other one. I think that there needs to be some work done following this meeting. I mean, we're not going to sort of get this organised now, but I mean, I think the general support is there. It's how we move it on, and I think that there needs to be some work, because I think everybody in the room is supportive of it. So it's the next step now. We've accepted it, we've looked at it, said it's good. Now where do we go from here? So it's, yeah, so we definitely need to move on that. I think, Christopher, do you want to come in again?
So just using the learning from that 8 years of East Midlands Development Agency action research, and learning from some of the international best practice in systematic interventions in citizen-led development, we, within the 3 years of this neurodevelopment pathway co-production, which children's hubs are one of the products coming out of that. We developed together a systematic delivery model. That delivery model brings together this sort of action and brings to bear the assets within the system that can most help with that into an easy to understand model. It's in fact on the JUCD website somewhere. It's there, but there's an offer to take a look at that as part of this, okay, and see how that will connect into systematic delivery that is relatively easy to introduce within the system and based on international good practice. Yeah.
Thank you. Thanks ever so much for coming along. I've really enjoyed that. I've learned a lot. I'm with Richard on this, and yourself, Chair, on the so what question. Where do we go now? So for me, I'd really welcome this coming back with a view about where does it stitch in? How does it inform change? How does it link to the integrated care strategy? And how do we make sure that we can sustain it? Because I think Richard's right. We have lots of brilliant things, but unless we sustain them, they often fizzle. So I'd really welcome that, including what's the partnership contribution to sustaining it, and how do we do that together, and what's the mandate we're giving this approach. So I'd really welcome it coming back, Chair. Thank you.
Jackie, did you want to come back, or?
No, it's okay, thank you.
So can I just sort of build on what Chris says? I'm very conscious that there's a temptation always to sort of suck things up to the widest level. And, you know, just as a thought, and maybe Kate's got to be, this feels to me as though it fits into place quite well, and that actually, you know, perhaps all the ICP needs to do is bless it and say, crack on. We can give you some support, but let it go on at place. I just fear this business of this awful temptation. I think we all suffer from it. If sucking everything up because we had a look at it, it now needs to come back. I'm not sure it does. Just a suggestion is, you know, maybe it could go into the place world and crack on really and influence there. The communities need to make the changes themselves really in a way. So just a thought.
Yeah, and for colleagues, I'm Kate Brown, and for the ICB, for Director of Place and Partnerships. And I think I would support that. So there can be a temptation to have a system. So having a tool that's available and shared and used and understood, I think, is really helpful. And anything that supports not only the tools and techniques, but also the culture and the behaviours. So it being endorsed by people as something that's really important in either individual programmes of work, which is communities of interest, or around local community-based place work, and place in its widest sense and at different levels. Because we have to recognise as well the work that happens in community development and public health programmes of work. So I think it's about building on that, strengthening that, and building that culture that acknowledges that as important. So this discussion here and giving that endorsement at senior level is really important, and having single tools and an understanding and oversight from here, well, not single tools, but a variety of tools and support to do that is important. And this board wanting to understand whether progress is being made and testing that, I think is really feels really important. But I would really support that where it might sit in terms of actual delivery and progress. It might not always be easy to see. We might have to ask people how it feels as to whether we're making progress, rather than being able to measure it in some of the ways we might ideally hope to do. But some of the work with CQC and asking people in the future whether they feel they've been involved, informed, engaged, that services are integrated is our best chance probably to understand whether we're making a difference as a system. So I think it's that middle bit of support and endorsement from the most senior level, but enabling that growth, that grassroots, and that support through all the tools we have, including, you know, all the great work that's happening through the voluntary sector and through population health support through public health at the moment.
Can I wrap this up and say I fully appreciate all of the comments and the support and the positivity around this work, which can feel very hard at times for people doing it. I think I will take away the suggestions, come back to certain people, and perhaps come back to the Integrated Place Exec where this started and report on how we're going to take this forward. Okay, thank you very much.
Yeah, I hate to say, but you have still got, if you don't mind, we've got some more at the back then.
Sorry,
I'm not sure which one, whether it's Jackie or Christopher.
Yeah. Sorry, I backed off from saying something, and then very beautifully and eloquently two people, Kate and over there, said exactly what I was trying to say, much more clarity than I was trying to say, because I was feeling a little bit emotional at the time, and I think it's really important. I was a little bit worried that the theme is for it to get sucked up into a higher level, the highest level, decided upon. That's what we do with the insight. Actually, the insight should be used at ground level. It really should be used at ground level. I think we need to really, what are we doing it for? My question is, who and what are we doing it for? It's about making the changes that people want, that they see to change their lives.
Yeah, if I can just clarify, because I'm one of the proponents of just bringing this back. To be completely blunt with colleagues, this will need support. It will not just happen. There will be colleagues that need to be paid to support it and create a framework to deliver it. So the reason for bringing it back here, I completely agree with all colleagues about where it should sit and the approaches to where it should be informed. But it does need a mandate. Statutory agencies will probably have to get around and continue to support it. And if we don't have that commitment and that mandate, there's a risk it will fizzle out. So the reason I'm keen to see it here is not to control it. It is not to suck it up into something and make it a huge bureaucratic challenge. It's to ensure that the statutory partners, particularly as part of the Integrated Care Partnership, recognise it, understand how it's going to be used, and commit to support it. And unfortunately, it comes back to resource. So that's the reason, and the Integrated Place Executive is a key component of the Integrated Care Partnership. But it comes from the Integrated Care Partnership in that sense. So that's that. Just to clarify, it's not to quash it or dispel it. It's to give it support, give it mandate, but also commit resource. Thank you. Back to you, Chair.
Yeah, go on then, Richard.
Sorry, I've got to say one more thing. The other reason as well that I think, it's great, it goes on at ground level, and I accept that. But at the end of the day, it's got to affect the way we commission services and commission stuff. So it's got to come up, otherwise, and that's if I sit in Public Partnership Committee and listen to what the people are saying to me, one of the biggest moans is that we don't join up what we say with what we do. So I don't think it can be left just at ground level. I'm sorry, from that point of view. It's got to be more practical than that, because that's the complaint I get at Public Partnership Committee, and proving that we don't just listen, we don't just collect people's ideas, but proving that we use them and actually use it to affect the services commission. Otherwise, we're losing credibility, I'm afraid. That's why I think it needs a bit further than that, if I'm being honest.
Well, as I say, I think Andrew's taking that on board. There is some more work to do, but in principle, it's great. It's how it integrates into everything. The funny part is I'm just sitting here and I'm thinking, I know I've been around a long while, but I was once involved in something called Derbyshire Sport, and we put in a bid, Andrew probably remembers, in a deprived area, and I thought it was an excellent bid, and we were turned down, and I was really upset. And the feedback was, oh yeah, it was wonderful, but you were telling that area just what they needed and what you thought they wanted. Did you ask them? And the answer, no. And I think that's how things have changed now. People are beginning to realise if you ask the people what they want, to a certain extent, I mean, there's got to be a bit of guidance, but you'll get far more buy-in, don't you, from people that are, sort of wanting to get involved and are being asked their opinions. So, yes, I was a bit reminiscing there. So, but thank you ever so much. I think it was a good presentation. I think, in principle, support that, but there's some more work to do, and I'm sure we'll welcome you back then.
Thank you.
Thank you. Thank you. Right, well, we're just going on to now just 3 items for information. One is the Integrated Care Strategy Well-Die update. Katie, are you doing that one, or I think? I'm not sure. I've got your name because we've got... Oh, sorry, yep, sorry, I missed one. I'm jumping the gun. So, integrated care strategy, stay well, update. Alison, sorry.
Oh, go this way. This way. Thank you, Liz, and apologies from Jane. She was unable to attend today, so I'm just picking up the paper on her behalf. I won't take you through most of it in any detail because it is largely for information, but just to note in 4.3 kind of outlines kind of much of the activity that's been taking place over recent months, and I think some of that came previously, so you'll be reasonably familiar with that. Kind of towards the end of, or kind of halfway down page 3, there's the reference to the sprint approach that we gave some detail on previously, and has been the approach used around smoking under the Stay Well area, which was the initial area of focus. And I think at the last meeting we did reference an evaluation of the use of the approach. And then that evaluation has now been concluded, and key findings of that are kind of at the bottom end of page 3. I think in large part it was felt to be really effective approach in supporting integration and action. I think there was some issues around clarity of process, but perhaps some of that was understandable. It was the first time we were using it. It was also reflected kind of around the intensity required from individuals in supporting that. So in terms of opportunities going forward, I think there's a reflection probably not to do back-to-back sprints, as that will probably burn out a lot of people, but to kind of reflect and think about how we take those approaches forward. But on the whole, I think it was felt to be a really successful programme of work. And some of the key achievements of the sprint are outlined in 4 point. Oh, I've just noticed there's two 4.7s, so apologies for that. Then the second 4.7 on page 5 kind of outlines kind of the considerations for the next priority focus of the Stay Well area within the Population Health Management Steering Group. But just noting, I suppose, following on from the discussion and reflecting on the conversation earlier around kind of the Start Well area, wonder, as I know we've got a substantive Stay Well update at the next Integrated Care Partnership, and perhaps it might be an opportunity for us to bring forward kind of a bit of an options appraisal and kind of thinking around those areas and kind of perhaps a preferred option and why we've got there that we can recommend to the board. So if the board is, or partnership is okay with that, then I'll propose that to Jane for us to bring forward next time. Kind of all the key outstanding actions in relation to smoking cessation sprint have now been handed over to the Tobacco Control Strategic Group, so that is now kind of effective and up and running. And I'll just pass you over to Ellie just to pick up kind of thinking around the system ambition and related objectives. That's okay, Ellie?
Yes, that's fine. Thank you, Alison. So I just wanted to pick up a slight error that's in the paper. So 2.2, the recommendation says to support the developed system ambition and objectives and the tobacco control system proposal. Well, that proposal isn't included today, but that will be coming to the next meeting, and there's going to be further consideration of elements of that proposal with the ICB later this week. So that's not in, but it will be at the next meeting. I just wanted to say a bit about the ambition, which is at the end of the paper. I'm sorry, I'm just scrolling back down. There we go. So 4.9. One of the things that came out of the sprint was a need to identify a vision for the system. There's been quite a lot of stakeholder consultation around this, and this is the final wording of that vision. So working together to make Derby and Derbyshire smoke-free by 2030, with some ambitions underneath. And the wording of that's been simplified as it's been through the strategic comms group, which is mentioned further up in the paper, that was one of the outcomes of the sprint. So the ambitions are a tobacco and smoke-free future for all, a healthier future for all, and a future free from the economic and social harms of smoking. And that has been through the Tobacco Control Board and is now here for endorsement. And I just wanted to say a little bit about why we've gone with that. So for anyone who's not been following the history of the national agenda on smoking, in 2019 the government set out a national ambition to be smoke-free by 2030, and the way that's defined is that adult prevalence will be at 5% or below. I can't overstate how challenging that will be at a national level and also at a local level, but nevertheless there is some action that's being taken around achieving that ambition, and therefore it felt right that Derbyshire should align itself with that ambition. Across Derby and Derbyshire, our prevalence stands at around 15%, so we're talking 122,000 adults across the county and city that smoke. There is additional funding that's coming into the county and to the city as part of the government's attempt to meet that ambition. So there was a review called the Khan Review in 2022, which identified that the government would miss that target by 7 years if it didn't take action. And so there were 4 critical recommendations for government, and we can see that action's been happening nationally on the basis of those recommendations. So the first one was to increase investment in smoke-free policies, and we've seen the new Stopping the Start fund that's come into local authorities specifically for an increase in community smoking cessation. The second recommendation was around raising the age of sale, and you will have seen that the second reading of that bill was voted through in Parliament last night. The third recommendation was around promoting vaping as an aid to quitting, and as part of the Stopping the Start programme we have seen vapes being made available across the country for stop smoking services to use. That is very specifically as an aid to quitting. And then the final recommendation was around improving prevention by offering smokers advice and support to quit at every interaction with the NHS. And we've seen some steps towards that through the launch of tobacco dependency treatment programmes. We've got one up and running in Derby and Derbyshire. Some areas don't have those up and running yet. But clearly we've got an opportunity here to build on those things and to really make some inroads into our smoking levels across the county and city. And smoking is still the leading cause of preventable deaths in Derbyshire and Derby and nationally as well. So the ask today is just an endorsement from the Integrated Care Partnership for this vision and the ambitions, and a full proposal, set of proposals around what we plan to do really to make some progress on this, as we've already agreed in this board that tobacco control is going to be our priority in that stay well space. That will come forward to the next board meeting. Thank you.
Thank you, Ellie. Any questions? Oh, we've got Alison and then Chris and then back. Yeah, thank you.
Thank you, Ellie. I'm not sure when you were talking about the 4 recommendations, whether they're the ones that have come from government or whether somebody, this body or another body has made those to government. I'm just quite happy to make myself quite unpopular in this forum and to say that I don't agree with the proposals around raising the age of smoking. I think it would be impractical. I think it's unjust from a sort of in the sense of differentiating the community like that, you know, one age being able to smoke. I'm not making a political point here, I'm really not. You know, I'm probably joining some Conservative MPs who spoke in Parliament yesterday. I think that I do not support that. I've made that clear to my Director of Public Health. It isn't what I would want to particularly support or champion in Derby. Obviously, if we've got National Parliament that has actually voted for this, then we're always legally required to follow the law, and I would always support that. But I do not think this is a practical solution, and I think it will have very unjust consequences. It will cause problems for shop workers, all sorts of practical issues. We don't have identity cards to assert people's age in this country. We don't do this for other products, as far as I'm aware. We don't do it in relation to red wine, for example, which would be highly unpopular with certain categories of the population. So whilst I support the overall approach, I personally, and I clearly recognise what happened yesterday, was it yesterday in Parliament, or the day before, I'm just making very clear publicly that I don't support that particular way of trying to stop people smoking for the reasons I've just said. Thank you.
Right. Thank you, Councillor Martin. We'll see what other views are. Chris, and at the back, and then Chris, yeah.
Okay, thank you, Chair. Thank you, Alison. So over the years, whilst I've been working in and around this sort of arena, the people who've managed to focus their attention in one area and do that exclusively for a long period of time seems to have delivered better results than people who flip between one subject and another. Listening to what Ali was saying about smoking cessation and smoking and tobacco control, feels like there's an awful lot of work still to be done in that space. So I want to go take us back to the second of the 4.7 paragraphs which you've got in your paper. It seems to be suggesting that we sort of maybe divert attention away from smoking cessation at the moment, and I just wanted to ask, is now the right time to be doing that, or should we be continuing to focus in on a critical area?
Thank you, Chris. If I start, and then I'm sure Ellie will have something to say. I think the intention is that the focus doesn't diminish on smoking, but that will now be taken forward through the tobacco dependency group that's now fully in existence and formed. So everything that was being taken forward kind of through the Stay Well work has now been exited and is being picked up by that group. So I think the intention is not to, I guess, drop the ball or kind of lose momentum on that. That's been taken forward through kind of another structure, if that makes sense, to enable us to start to pick up kind of some of the work kind of within the wider system. But I'll let Ellie comment.
Thank you. I have to say I've expressed similar concerns to you about that, Chris, in terms of how quickly do we move on to something else, and is that what we've agreed to do here? So I think in the same way that we had the conversation about Startwell and the prioritisation within that, then I think that should be a conversation that comes back here. But I think, as you've said, Alison, recognising that Jane's not here to answer the questions, it's something that can be brought forward to this board for a further discussion about actually, you know, how do we want to progress what is in the overall integrated care strategy around Stay Well, and do we want to continue our focus in, and for what period of time do we want to continue our focus on one area? You know, when do we consider that to have been lifted, if you like, to a higher plane of activity that's going to deliver for the system? When will we be ready to look at the next thing? I think that's something for this board to consider, so I think it's something we should bring forward next time.
Come back in there, Chair. So if I take those points then into the second 4.7, and if I add kind of smoking back in and kind of how that's taken forward as part of the discussion in terms of next steps for the kind of population health management steering group and kind of the Stay Well focus, if I add that kind of back in.
Yeah, so if I can just come back on that a little bit, Alison. So I think it's really important that we do understand where we're focusing our attention and for how long. And partly that's because I recognise that we're entering a very, very difficult resource-constrained environment. And I don't want to sprinkle a little bit of resource all over the place when we've got real opportunities to deliver some dramatic improvement in specific areas.
Hi, Gino Di Stefano, UHDB. Just kind of building on the resource point, I think smoking cessation is a great example of something where all partners can contribute. This isn't about what a small team somewhere does with specialist skills. I think what the sprint demonstrated was the breadth of partners that engaged with a view to saying, what's my part in this? And I think the sprint was a really powerful example of how it felt different. This is a key priority for all. It didn't feel like business as usual. And while I know we can't do lots of sprints at the same time, I do think there's something about wider adoption of the approach where it's appropriate. And I think the learning in here is helpful for the partnership to reflect on as we think about how we create energy behind things. But to the point Chris highlights around resources, it doesn't cost much for a person to have a conversation with somebody in front of them that they're already seeing. I think there is something about clear messaging and expectations of all those people that have interactions with people day to day. This needs to be part of the conversation. But of course, that also requires us equipping people with the confidence and the skills and the ability to redirect people to support services where needed. So very helpful process and a really good plan. I just wanted to say, as one of many partners engaged in this recent exercise, how positive and constructive it felt. So a thank you, as well as an endorsement of the recommendations.
Yeah, thanks, Chair. And thanks for the report. I probably need to be a little stronger, really, on the view about priority. So I am concerned that we're even entertaining doing more sprints before we've established a programme, agreed to the programme, established it, monitored its delivery, and moved us forward. I think there's a huge risk in it. So I want to really support Ellie and Chris and colleagues about saying the sprint's been really helpful, thank you. We now need to embed this process. We need to actually agree the full programme of work across the partnership in this area, and then we need to deliver. I think we need a really considered conversation about when's the time to add some more priorities in. We've not had that conversation, and I think we should. And I think we should have an evidence-based view about when's the right time to move to the next, whilst not letting go of the one that you've got, because it will take many years to solve. So I'm in that space of probably objecting to further sprints. I do recognise when colleagues probably think, oh, we've done this now, what do we do now? Let's utilise those skills in a different way, and I'm thinking about monitoring, oversight. You know, there's things that group who've been sprinting can do to really help us whilst we've got the programme running when we've agreed it. So thank you, Chair. I want to really support that view. Thank you.
Well, we've reached an impasse. I mean, you put forward the suggestions on the smoking. Councillor Martin's indicated that there's one item that she's not does not support. Do we move? Yes, Ellie, go on.
Sorry, I was just going to come back and say, actually, all we're asking for today is endorsement of that vision and the ambition statements, that's all, and then the full conversation that we've just started can be picked up at the next meeting. So I just wanted to clarify, and actually the raising the age of sale, I appreciate it's everybody, you know, everyone's got their own view on that, but that's a national thing, that's not part of what we're talking about here.
Okay, so we'll move that on to the next meeting. Yes, Councillor Martin.
And if I may, Carol, because I know I just said something a little bit probably controversial in this context, absolutely not in a political way, happy to align to some of the people in your own party if you like, is that I think you're absolutely right, Ellie. I mean, I totally agree, actually, in terms of the broader issues here, I totally agree with what Chris has just said. In fact, we were saying this earlier on, and I was saying it in a cabinet meeting here earlier this morning. It's great that things have opened up, and it's great that people have been integrated and expansive, but there's got to be, it comes to a point when there has to be a focus on doing what we can actually do. And so I think that's really important. I mean, you know, I would add another little thing, that the whole thing about the age-related thing could take up enormous amount of resource and not be effective. So, you know, if we're not going to sell it, I think there are other ways of doing it. But as you say, that's outside the scope of this forum. So I apologise if I overstepped the mark there, but I did want to register my strong dislike of that policy. But we know it's going to be resolved nationally anyway. Thank you.
Yes.
Sorry, Kate, that I jumped on. So it's just the age well update.
Yeah. Thank you, Councillor Martin. So last time we did a bit more detailed about this priority, and it's interesting listening to the conversation this afternoon about the specific. In the other two key areas of focus within the strategy, we have much more targeted priorities in terms of school readiness and the smoking. With this, the ambition is around that integrated services and helping people in crisis and then returning to independence following escalation, with a real focus on how we are working as partners and how we're integrating services to deliver those ambitions. So the update this time gives a bit more information about work that's underway around the discharge programme of work. Obviously lots of very pressing issues about discharge here and now, here you know, day to day, but this work's trying to then look at the improvement that's needed across all the pathways of discharge, including quite significantly community-bedded care, which both health and local authorities operate, and looking at opportunities there, and thinking also as well in terms of our role with the PVI sector for those people who are discharged straight into nursing or care homes, which we try and minimise as much as possible in terms of trying to maximise their opportunity to return home before going into long-term care. So lots of pieces of work trying to support improvements across those pathways. But interesting as well, given the discussion we had earlier, you'll note in the report that we talked about an ambition to improve the involvement of citizens in shaping discharge outcomes and pathways. It's not necessarily an area where we traditionally probably have talked to people very much about their experience, but as is noted in the paper, Health Watch are in the process of appointing somebody with that particular focus, and also it was mentioned in the presentation earlier that Alison mentioned about some insights work and feeding that into the discharge work in particular, but also more broadly we're making connections. In fact, just this week had a conversation about how the broader Ageing Well, Die Well programme incorporates the insights as they emerge through the tools, as we heard earlier. So really trying to make sure that we're connecting up the work that we're doing, informed by the data and the pressures, but also by the insights that we have in terms of how we approach that. Also mentioned in the paper is just a focus of the fact that at a local level there's work making sure that we're developing those services we referenced last time in terms of falls response, falls prevention, and taking opportunity where a person has had a fall that's not meaning they need to be taken to hospital, that we then link that into prevention, follow-up services. And it's been because we've got an overall approach but that's developed and delivered at a local level, that's taken time to establish but has really been useful in terms of setting an approach where local places determine how that single model might work in their area and how that's then delivered, and all about improving our resilience and reducing pressure and giving people obviously a better experience by not being in a hospital if they don't need to be. We've just given a real high level this time because we did give more detail last time. We made a suggestion here as well that we focus very much on some of the Age Well, the team up, the discharge work, and we thought that it might be interesting to the partnership to hear some of the work that's underway around palliative and end-of-life care and the partnership work and the strategic approaches that are being taken there. As I say, this area of work we've got, which we're sort of trying to bring through the partnership issues around the delivery of this element of the strategy, rather than honing on a specific issue. And finally, to mention around that, we did endorse last time the priority of that transformation work, some of which we're aiming to accelerate with external support, but the opportunity to do that is still part of the planning decisions that the system needs to make in terms of where we can invest for 24-25, and this work will all continue, but the pace at which it continues will be to some degree dependent on the outcome of those final operational and financial plans. Thank you.
Thank you, Kate. Any questions for Kate? No? Right, thank you. So we'll move on to the Joint Local Government Association, the facilitated workshop. So are you going to do that, Alison, or? Yep.
Maybe a bit of a double up, but yeah, so this item is largely for the information of the partnership. So tried to kind of broadly capture the purpose of the session that was run. I can't remember when it was now. It feels like an age ago, but actually probably wasn't. I think it was last month. To capture the purpose and what we were trying to achieve through that session, and then in the appendix, kind of an overview of the discussions that were had on the day and kind of some of the thinking in terms of next steps around that. I kind of picked out in 4.5 kind of some of the next steps that are already in train. So we're trying to get scheduled, aren't we, Kate, kind of a meeting in terms of follow-up with the facilitators that ran that session to discuss the output and the next steps. I know we've got a meeting, I think, between the ICP and Health and Wellbeing chairs, so yourself, Carol, Alison and Richard and I think Chris coming up in the next week or two to kind of consider the next steps. So I guess we're really wanting to think about is whether, you know, it's a really good event and session, but kind of what's next and what do we need to take forward. And Kate and I and Hayley, colleague from County Council, are also thinking of some of the actual what the practical things that we could perhaps start to be getting on with now to be able to take that forward. And I'd just bring your attention to, I think, the very last page of the appendices where we did, I think at the end of the session, pick out a number of suggested actions proposal. And I think perhaps the first one of those around strategic and compelling narrative of our priorities, I suppose just kind of reflects some of the discussion that we've had through today, and I think probably a strong sense that actually that is something we need to do in terms of kind of really determining, shaping actually what can we reasonably focus on, and have we got a clarity of that within the system, and perhaps what the health and wellbeing boards take forward and what the ICP takes forward. So it was really just to remind those that were there that it happened and we need to take it forward, but also to support those that weren't in attendance to have a bit of an overview of kind of what happened on the day. I don't know if, Kate, if there's anything else you wanted to...
Nothing, thank you. Thank you.
Yeah, I mean, the only thing that I was disappointed was I thought it was quite useful, but I think there was still quite a lot more questions came out with not all the answers. But as I said, I did think it was useful. A lot of it was about readiness as well, which was pertinent to today's meeting. I was disappointed that we didn't get the proper feedback from the LJ people that took the I thought that they would, because we were spread around the room and different tables, we didn't all know what was happening on other tables and we didn't get all the message. Normally they take the things away and feed back, and that didn't happen for some reason, and they just left all the post-it notes and everything else and sort of said, you more or less, well, you learn from that. Well, so I think we are persevering with them and ask them for a little bit more feedback on that, because I think that was part and parcel that we wanted. So, and we are looking to, in a few months' time, perhaps have them back again. But as I say, I think that they need to sort of give us a little bit more information about, because as I say, we only knew what our actual tables were saying. But Alison.
Yeah, you're absolutely right, Carolyn. We are, and particularly Hayley, who you know well, is kind of pushing them hard on that, and that we'll be picking that up when we meet with them shortly. So yeah, and I suppose the other thing to say is that in the kind of interim, in advance of that meeting, we are all having a look through and scanning kind of the content of those. I can't remember if it's it's not next week, so I'm on leave. The week after, we're going to sit in a room and kind of scan kind of the paperwork that we had on those session and kind of look alongside this, and just to make sure that we're not missing anything, but absolutely getting our LGA facilitator colleagues back in the room to support us in actually pulling perhaps something a little bit more concrete together and supporting us in the next steps, Carol.
I mean, somebody did come back to me because with my borough hat on, you know, we've included on the Derbyshire Health and Wellbeing Board 8 districts and boroughs because we're slightly different to the unitary, and there are some that take on board that they can do a lot with housing and everything else and planning and contribute to public health and everything else. But there are one or two of the areas that don't seem to grasp it, and I had one of their councillors on. So I've got to be careful, because apparently I upset somebody because I said I didn't sort of say some districts and boroughs. Most, the majority, understand and want to get involved. Others, what's it got to do with us? You know, so I think it's just we need a little bit more sort of pushing on that. So I think Richard and Christopher, and did I see your hand, Alison? No. So Richard, yeah.
Really quick from me, but you're not going to be surprised that, you know, when we do those priorities, I'll be looking to we link them back to what's coming from the population. Do you know what I mean? So it doesn't appear top down and shows we've listened. And I think those are the questions we've got to be asking all the time. I think that's what's coming out today. That's why I brought it today.
Yeah, thank you. And just to endorse what you said there, Carol, because we were there. And first of all, to say thank you that we were there. You know, that was a big breakthrough for the voluntary sector. And it was there was a lot learned, you know, by being present there. I did find that in that structure, as you were saying, it's sort of begun a process which hasn't continued. And now, of course, we are in the position of making decisions are being made, as we've seen here today already. And things were put forward at those tables which may have influenced the sort of discussions. So it would be good if we could get that feedback from that, exactly as you've said. But secondly, I did notice, as someone who's been involved in a lot of those sort of sessions, that it was largely around primary, you know, what people were saying, which is good. These were experts who were then representative. But little discussion just on our table on Startwell around the secondary research. So, you know, what research has already been done that lists all the priorities, for example, for school readiness. So it was very clear that that was not there, and obviously is imperative if we're making decisions on this. Absolutely imperative that we have that information. Thank you very much. Great that there was dialogue. Yeah, and it's this, what people are saying, that the dialogue comes up and position papers are put to here. It did happen on that ND Pathway one, where the dialogue all came in, and then it was ready to be positioned. So that model's a good model to look at for that. Thank you.
Right, well, with that, I see the clock ticking up. I think we're just about going to make it for 4 o'clock. So we're on to the last item, which is you, Alison, and it's just items for the forward plan.
Yeah, thank you, Chair. So I won't take colleagues through. So the paper just reports what we've got scheduled provisionally on the agenda for the next meeting, and I think the provisional meetings after that, and just request that if there's any other items to let us know.
Yeah, I think we agreed on the one workforce approach and across health and care, and I think we should be planning regular updates about that. So if we could, I'd be grateful. I think that item we've just had around engagement and involvement needs to be stitched in the right way, of course, in the right way. And I do wonder about whether we get more regular formative updates around place. I just wonder about weaving them in, as opposed to having them when they come under specific items. We actually have a strategic view. Just a thought. Thank you. Back to you, Chair.
Yeah, thank you, Chris. That's really helped. I'd actually scribbled a note kind of somewhere in my notes today just around perhaps the enablers, because I think we've got things like the data in section 251 that had been incorporated under kind of the stay well, but it feels like probably workforce kind of data and insight are probably core components that we perhaps need to think about kind of more systematically and join up. So I'll take that on board. Thank you.
Right, well, that concludes the meeting, and with a few seconds to go, you know, I think that the meeting today, I think it's generated more work, you know, in the next few weeks, and you know, I think that really interesting presentation. So I hope you found them all useful and the information. So thank you for attendance, and declare the meeting closed at about 5 seconds to go. Thank you.